Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 182 of our pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, why a 57-year-old male patient presents to you accident and emergency department with complaints of new fever, worsening abdominal pain for 3 days, and lightheadedness. He has a past medical history significant for ILEO colonic Crohn's disease, child PUB, alcoholic liver cirrhosis. He has no known drug or food allergies. Regarding his surgical history, he underwent a subtotal colectomy 3 months ago with stoma creation. His admission was complicated by an anastomotic leak and intra-abdominal collection requiring repeat surgery. According to his pertinent labs, fluid cultures grew a strain of Klebsiella pneumoniae that was positive for extended-spectrum beta-lactamase (ESBL) production, and he completed a course of ertapenem therapy. The results of the NARES screening tests for methicillin-resistant Staphylococcus aureus (MRSA) are negative. So my question to you is, which of the empiric antimicrobial regimens listed below would be recommended for YAY's suspected intra-abdominal infection basing on guidelines from the Surgical Infection Society, abbreviated as SIS, and Infectious Diseases Society of America, IDSA? Would it be A. cefepime and vancomycin, or B. meropenem, anagulafungin, and a single dose of amikacin, or C. ceftazidime, avibactam and micafungin, or D. meropenem, vancomycin, and fluconazole? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. meropenem, anagulafungin, and a single dose of amikacin. This patient with a recent hospitalization for surgery and infection has a complicated, healthcare-associated intra-abdominal infection. He is infected with an ESBL-producing organism, although he is not colonized with MRSA because the results of MRSA screening are negative. According to SIS-IDSA guidelines for complicated intra-abdominal infection, see Table 3, empiric antimicrobial therapy with activity against ESBL-producing Enterobacteriaceae is warranted. Empiric therapy with an echinocandin is preferred over azole antifungal agents for severe infections, according to the IDSA Clinical Practice Guideline for the Management of Candidiasis. Vancomycin for MRSA coverage is not required at this time. Therefore, meropenem, vancomycin, and fluconazole is inappropriate. Ceftazidime, avibactam plus micafungin is not appropriate because it lacks anaerobic coverage. Metronidazole is needed for anaerobic coverage, and because metronidazole plus ceftazidime, avibactam was non-inferior to best available therapy for the treatment of complicated intra-abdominal infections in the REPRISE study. Empiric therapy with an echinocandin is preferred over azole antifungal agents for severe infections, according to the IDSA Clinical Practice Guideline for the Management of Candidiasis in High-Risk Patients. Meropenem and Anadula fungan and a single dose of amikacin is the best choice for this patient. Cefepime plus vancomycin is not appropriate because it does not provide adequate coverage for ESBL-producing organisms. Vancomycin for MRSA coverage is not required at this time. Please advance to the next question. An abdominal CT scan is done and it shows an intra-abdominal collection with possible bowel ischemia. YAY underwent a total colectomy with insertion of a surgical drain. Blood cultures obtained upon admission have no growth. So my question to you is, what would be the optimal duration of antibiotic therapy for YAY after adequate source control is achieved surgically? Would it be A. 24 hours, or B. 14 hours, or C. 8 days, or would it be D. 4 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. 4 days. In the STOP-IT trial, a median of 4 days of antibiotic therapy was compared with a median of 8 days of antibiotic therapy after source control surgery for complicated intra-abdominal infection. There was no significant difference between the two durations in the primary endpoint, which was a composite of surgical site infection, recurrent infection, or death within 30 days. Therefore, 4 days is the most appropriate duration. 8 or 14 days is not appropriate. 24 hours is not sufficient according to guidelines from the Surgical Infection Society and the Infectious Diseases Society of America. 24 hours of antibiotic therapy for complicated intra-abdominal infection may be adequate only in the absence of intra-abdominal collection. Please proceed to the next question. And the next question reads, the surgical team discharged YAY back home, he remained well, and has been free of infections. 24 months later he presents back to the hospital with worsening ascites, fever, and altered mental status. Abdominal paracentesis is done and results of ascitic fluid sample are as follows. He has a WBC of 1069 colony forming units per millimeter cubed with 53% segs, 11% lymphocytes, 35% monocytes, 1% eosinophils, 0% basophils. Ascitic fluid and blood cultures are pending. So my question to you is, which of the following would be the best treatment regimen for YAY at this time? Would it be A. IV ceftriaxone 2 grams once daily for 10 days, followed by secondary prophylaxis with oral norfloxacin 400 mg once daily, or B. IV ceftriaxone 2 grams once daily for 5 days, followed by secondary prophylaxis with oral norfloxacin 400 mg once daily, or C. IV cefotaxime 2 grams thrice daily for 5 days without secondary prophylaxis, or would it be D. Initiate secondary prophylaxis with oral norfloxacin 400 mg once daily without initial IV treatment? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. IV ceftriaxone 2 grams once daily for 5 days, followed by secondary prophylaxis with oral norfloxacin 400 mg once daily. The clinical presentation of this patient, who has a history of liver cirrhosis, should raise suspicions about the possibility of spontaneous bacterial peritonitis, abbreviated as SBP. The diagnosis is made based on the presence of an elevated absolute polymorphonuclear leukocyte, abbreviated as PMN count of 250 cells per millimeter cubed or higher in acytic fluid. The absolute PMN count in YAY is 566 cells per millimeter cubed, calculated by multiplying the percent segs expressed as a decimal by the total white cell count, or 0.53 multiplied by 1069. Empiric treatment with an appropriate antimicrobial agent plus secondary prophylaxis is warranted. Intravenous ceftriaxone 2 grams daily for 5 days, followed by secondary prophylaxis is the best choice. Providing secondary prophylaxis without treatment is inappropriate. Intravenous cefotaxime is a recommended treatment for spontaneous bacterial peritonitis, but long-term secondary prophylaxis is needed for this patient because of high rates of recurrence after the first episode, 69% in 1 year. Intravenous ceftriaxone 2 grams daily for 5 days, followed by secondary prophylaxis, is the best choice. Intravenous ceftriaxone 2 grams daily for 10 days, followed by secondary prophylaxis with oral norfloxacin 400 mg daily is not the best choice. Clinical trials demonstrated that a 5-day treatment course was as efficacious as 10 days for treating spontaneous bacterial peritonitis. Please progress to the next question. And the next question reads, which of the statements listed below outlines the most appropriate, currently accepted approach to the pharmacologic management of appendicitis based on clinical evidence? Is it A. There is no significant difference in outcomes between 3 days and 5 days of antibiotic therapy after appendectomy for complicated appendicitis, or B. Surgical intervention plus antibiotic therapy is superior to antibiotic therapy alone for the treatment of uncomplicated appendicitis, or C. A 5-day duration of antibiotic therapy after appendectomy is superior to 3 days of antibiotic therapy for preventing infectious complications after appendectomy, or is it D. Antibiotic therapy without surgical intervention is non-inferior to surgical intervention plus antibiotics for the treatment of uncomplicated appendicitis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. There is no significant difference in outcomes between 3 days and 5 days of antibiotic therapy after appendectomy for complicated appendicitis. Antibiotic therapy alone is inferior to surgical management plus antibiotic therapy for acute appendicitis, as demonstrated by Salmon and al. 2015 cohort study by Van Rossum al. 2016 demonstrated no significant difference in infectious complications between 3 days and 5 days of antibiotic therapy. Only perforated appendix was a significant predictor for postoperative complications. Studies conducted to date comparing surgical intervention plus antibiotic therapy with antibiotic therapy alone were not designed to test superiority, so no conclusions can be made about the superiority of surgical intervention plus antibiotic therapy. Several recent non-inferiority studies have shown that a short course, 3 days, of antibiotic therapy is effective for the treatment of uncomplicated appendicitis with surgical intervention. There were no significant differences in outcomes between 3 days and 5 days of antibiotic therapy. Please advance to the next question. And the next question reads, PZO, a 64-year-old male patient with gastric cancer is admitted electively for a total gastrectomy. After surgery he was NPO, and couldn't take fluids, or medications orally, so total parenteral nutrition was initiated. Postoperative day 3, he developed fever, leukocytosis, and respiratory distress requiring intubation and surgical intensive care unit admission. 24 hours later urine and endotracheal aspirates were positive for Candida species, with blood cultures still pending. So my question to you is, which of the therapeutic approaches listed below would be the best approach to managing PZO's probable infection? Would it be A. Remove his central venous catheter to reduce the risk for invasive fungal infection but no antifungal drug therapy is required, or B. He probably is only colonized with fungi, so no antifungal treatment is required, or C. Initiate empiric antifungal therapy with micafungin because of his high risk for Candida infection, or would it be D. Initiate empiric antifungal therapy with micafungin for pneumonia caused by Candida? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Initiate empiric antifungal therapy with micafungin because of his high risk for Candida infection. Initiate empiric antifungals for pneumonia. Pneumonia caused by Candida is rare in the absence of severe immunosuppression. Candida from the sputum almost always reflects colonization. Initiate empiric antifungal therapy with micafungin because of his high risk for Candida infection is correct. PZO is at high risk for Candida infection because he presents with multiple risk factors for invasive candidiasis. These include recent intra-abdominal surgery, presence of a central venous catheter, receipt of total parenteral nutrition, and the presence of candidal growth at 2 separate body sites. Clinically, the patient shows systemic signs of infection, so empiric antifungal therapy should be initiated. Therefore, antifungal drug therapy is warranted. Removal of the central venous catheter in patients at high risk for Candida infection has been shown to significantly reduce the rate of invasive Candida infections. Nevertheless, antifungal drug therapy should still be administered. Please proceed to the next question. And the next question reads, BAB, a 66-year-old male patient presents to your accident and emergency department with watery diarrhea, leukocytosis of 12,000 cells per milliliter, and a serum creatinine of 1.1 mg per deciliter. He has a past medical history significant for congestive heart failure, type 2 diabetes mellitus and prostate cancer. He was recently discharged after a 14-day hospitalization due to bacterial pneumonia. A stool sample is sent to the clinical microbiology lab, and it tests positive for Clostridioides difficile toxins. So my question to you is, apart from blood cultures, which of the following biomarkers would you suggest using as part of the diagnostic workup for invasive candidiasis in BAB's clinical scenario? Would it be A. serum galactomannan, or B. serum beta-D-glucan, or C. serum interleukin-6, or would it be D. serum procalcitonin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Serum beta-D-glucan. An FDA-approved procalcitonin diagnostic test is available to help guide the discontinuation of antibiotics, but it is not designed as a biomarker for use in the diagnosis of invasive candidiasis. Serum interleukin-6, abbreviated as IL-6, is elevated in septic patients with invasive fungal diseases. However, there is no FDA-approved serum IL-6 test. Beta-D-glucan is a cell wall constituent of Candida and other fungal species. The use of a serum beta-D-glucan has been approved by the FDA as an adjunct to blood cultures for the diagnosis of invasive fungal infections. Galactomannan is a cell wall component of Aspergillus. An FDA-approved serum galactomannan test is available, but it is not used for the diagnosis of invasive candidiasis. Please progress to the next question. And the next question reads, which of the regimens listed below would you recommend for BAB's clinical scenario above now, based on guidelines from the Infectious Diseases Society of America (IDSA) and Society for Healthcare Epidemiology of America (SHEA)? Would it be A. Vancomycin 125 mg orally 4 times daily for 14 days, or B. Vancomycin 125 mg orally 4 times daily for 10 days, or C. Fidaxomicin 200 mg orally twice daily for 14 days, or would it be D. Metronidazole 500 mg or 400 mg orally thrice daily for 10 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Vancomycin 125 mg orally 4 times daily for 10 days. This patient has experienced an initial episode of non-severe Clostridioides difficile infection, abbreviated as CDI. The 2018 IDSA-SHEA-CDI guidelines recommend fidaxomicin or vancomycin for a planned 10-day course as the preferred therapy in these cases. Metronidazole 400 mg or 500 mg by mouth 3 times daily for 10 days is inappropriate. The IDSA-SHEA guidelines recommend metronidazole as an initial therapy for non-severe CDI only if fidaxomicin and vancomycin are not available. Vancomycin 125 mg by mouth 4 times daily for 10 days is the best choice. Fidaxomicin 200 mg by mouth twice daily for 14 days is inappropriate because 14 days is too long. Vancomycin 125 mg by mouth 4 times daily for 14 days is not consistent with these guidelines. 14 days is too long. Please proceed to the next question. And the next question reads, BAB was discharged after 5 days of antibiotic therapy to complete therapy on an outpatient basis. He returns to the emergency department 2 weeks later with new-onset diarrhea, abdominal pain, leukocytosis of 13,000 cells per milliliter, and a serum creatinine of 1.2 mg per deciliter. A stool ample tests positive for Clostridioides difficile toxins. So my question to you is, which of the following therapies do you recommend for BAB at this time based on guidelines from the Infectious Diseases Society of America (IDSA) and Society for Healthcare Epidemiology of America (SHEA)? Is it A. Fidaxomicin 200 mg by mouth twice daily for 14 days, or B. Fecal microbiota transplantation, or C. Vancomycin pulse tapered regimen for 21 days, or is it D. Vancomycin 125 mg by mouth twice daily for 10 days? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Fidaxomicin 200 mg by mouth twice daily for 14 days. Fidaxomicin 200 mg by mouth twice daily for 14 days is appropriate for patients like BAB with recurrent Clostridioides difficile infection who received a standard course of vancomycin for the initial episode, according to the IDSA-SHEA guidelines. Vancomycin 125 mg by mouth twice daily for 10 days is inappropriate because a different therapy should be used for recurrent episodes. Pulsed tapered vancomycin is recommended for the treatment of a second or subsequent recurrence, not the first recurrence, and the regimen is given over 8 weeks, not 21 days. The IDSA-SHEA guidelines recommend fecal microbiota transplantation only after a second or subsequent recurrence. So there you have it, our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 183.